I'm very honored to be here to present Medicine Grand Rounds, and thank you to the coordinators for inviting me today. So today we'll be talking about anal cancer prevention, and we'll talk a little bit more in depth about screening methods and high-resolution anoscopy. The PEACH stands for the name of the program, which is Prevention and Education of Anogenital Cancers and HPV-associated diseases. And this is our anogenital cancer prevention program here at Stanford. These are my disclosures. And I apologize if I'm getting over a cold, if I need to take a sip of water during the talk. But our objectives today are to review HPV and anal cancer epidemiology, to review newly published anal cancer screening recommendations that were just published January 31st, and to understand how to perform anal cancer screening using these recommendations. We'll talk a little bit about the high-resolution anoscopy procedure, which is abbreviated HRA, and we'll go over how to refer to our program here at Stanford, the PEACH program. So just a pretest question for people in the audience. Which of the following groups has the highest number of anal cancer cases in the United States? And I have a small group here, so I'll poll them, but the people online can also think about what their answer would be. Is it, and please raise your hand if you pick this answer. Is it A, heterosexual men, B, men who have sex with men, C, heterosexual women, or D, transgender women? I'll go through them again. A, B, C, and D. Okay, good. So the majority here got it correct. The people with the highest number of cases in the United States are heterosexual women. So talking about the anus is kind of uncomfortable for people. And so I just want to open up with something. This is a kid's book that my kids really like. It's an author from New Zealand that likes to write silly books. And this is a kid who says, I need a new butt. They say, I need a new butt. Mine's got a crack. I can see in the mirror a crack at the back. Did I do it on the slide? Or on the banister inside? Or when I jumped my BMX? Or with the fart that happened next? Of course, the fart, that's what blew my butt apart. Split the thing clean in two. Now I wonder what to do. I need a new one, a green one or a blue one, a fat one or a thin one, a wood one or a tin one, or yellow spotted, purple dotted, a butt with color, a butt with flair, happy pride. Why not an arty farty butt, one not to be forgotten, with watercolors on the top and a mural on the bottom? So this kid goes through all the different butts, tries on different ones, even an alien butt, a bumper butt, but none of them really seem to work for them. No, I think it's all too late. The cracked butt is my fate. I'm here on my own in this cracked butt zone. No one to care, no one to share. Wait, what's that I hear? That's outrageous. Are butt cracks contagious? Dad, your butt crack is showing. I hope you all enjoyed that. And now we'll move on to something a little bit more serious. So we're talking about human papillomavirus today, or HPV, which is associated with many anogenital conditions in males and females. You can see here it causes genital warts, vulvar, vaginal, cervical, penile, scrotal, anal, intraepithelial neoplasia, which are the precancerous lesions, and cancers. We know that HPV is the most common sexually transmitted infection in the world, both by prevalence and has a very high incidence on a yearly basis. The estimated lifetime probability of acquiring HPV is 85 to 90%. And this is something that I really try to talk to my patients about because there's a lot of stigma associated with HPV, but it's so common. This study looked at people with at least one opposite sex partner and estimated the lifetime prevalence. And so we know that the majority of people do get exposed to HPV at some point in their life. When we look at the burden of disease associated with HPV, we can see that genital warts is the highest incidence, the most common. And when we look at the cancers, we see that cervical cancer is the most prevalent. And cervical cancer is so common in a lot of countries because there's no screening available. We do have screening here in the US. We're very lucky. It was the first cancer screening test. But we still do see cervical cancer here. The next most common is head and neck cancer. And in the United States, the head and neck cancers associated with HPV have actually superseded the numbers of cervical cancer since we have screening for cervical cancer. And then the next most common is anal cancer. And you can see here the breakdown is about 2/3 women and 1/3 men. So more women than men get anal cancer. And then the less common cancers caused by HPV are vulvar, vaginal, and penile. When we look at the US data, we can see that in females, cervix is the most common HPV-associated cancer, followed by anus, followed by vulva. When we look at males, we can see that the oropharyngeal HPV-associated cancers are the most common in males, followed by anus and penis. Unfortunately, rates of anal cancer are rising and have been rising about 2 to 3% per year in the United States. And over 90% of anal cancers are associated with high-risk HPV. And HPV-16 in particular is highly implicated. It causes about 80% of anal cancers. When we compare cervix and anus cancer over the past 4 decades, you can see that cervical cancer rates are going down. The Y scale is different for the two because anal cancer is not as common of a cancer as cervix, but the rates are going up over this time period and continue to go up. When we look at the global burden of HPV-associated anal cancer by sex, you can see that for men, the darker colors are areas of higher incidence, and you can see the incidence rates are higher in the US, in Western Europe, in Australia, in some countries in Africa and South America. And for women, you can see that there's higher rates in these same places, but in even more countries in Africa and South America. We know that HIV is a big risk factor for anal cancer. HIV makes it harder to clear HPV from your system and increases the risk for anal cancer. But how much of anal cancer is associated with HIV? Among men, which is the blue bar, you can see that about 21% of anal cancers in men are in people living with HIV. And in women, only 3% of the anal cancers in women are in people living with HIV. When we look at this more broken down by region, you can see, by continent, you can see that in women, the HIV association with anal cancer is mostly in Africa. And then when we look even more granularly, you can see that sub-Saharan Africa is where you have the HIV-associated anal cancers, which we know that that's an area of very high HIV prevalence as well. And interestingly, when you look at the numbers for the United States for men, you can see that 33% of the anal cancers in men in the United States are in people living with HIV. So 1 in 3. This was a study that we did. I worked at Kaiser before I came to Stanford, and this was with colleagues at Kaiser. We presented it last year at ASCCP. We were looking at incidence rates of HPV-associated cancers in the Kaiser Permanente Northern California database. And we looked at it by age group and over time from 2006 to 2020. You can see that in the younger age groups, cervical cancer has the higher incidence rates. But as people age, and this is all in women, as women age, the anal cancer rates supersede the cervical cancer rates at age 55, start to go up there. And when we broke it down by age less than 50, you can see that cervix is the most common cancer in this younger age group. When we looked at age 50 and older, you can see that over the time period of the study, anal cancer was more common than cervical cancer. And so we know that screening for cervical cancer has helped to decrease the incidence. And we are hoping that as we start to implement more screening for anal cancer, we can see some of these rates start to come down. So moving on to some risk factors for anal cancer. We already mentioned that HIV is a big risk factor, probably the #1 risk factor for anal cancer. Non-HIV immunosuppression is another risk factor, and particularly people who have been immunosuppressed for a long time, and people who've had solid organ transplant for at least 10 years seem to be at the highest risk, and I'll show you that data a little bit later. We know that sexual gender minority status is another risk factor for anal cancer, and particularly men who have sex with men and transgender female are at much higher risk of anal cancer. And we know that history of lower genital tract HSIL or cancer, and HSIL stands for high-grade squamous intraepithelial lesion. This is considered a precancer. So having a precancer of the vulva, the vagina, or the cervix, or cancer in one of these locations increases your risk for anal cancer, which is another HPV-associated lesion. We know that smoking allows the HPV virus to persist in the body and makes it harder to clear, and this increases the risk for all of these HPV cancers. And multiple sexual partners is a risk factor, primarily because it increases your exposure to the high-risk HPV types. And for HPV, there's many different types that can affect the genital tract, but the high-risk types are the ones that can cause cancer, have been found in cancers. There are about 13 of them that we test for when we do HPV testing. Other risk factors are a history of anal warts in either females or males. And then one thing I really wanted to talk about today was history of anal intercourse or receptive anal sex. There's a big misconception here that you have to have had receptive anal sex in order to get anal cancer, and that's not true. I have many patients that have had anal cancer that never had anal sex. So I think that that's one thing I want to make sure people understand. It's possible to get exposure to HPV in the anus without having anal sex. Of course, you're going to have a higher likelihood of getting HPV in the anus if you're having receptive anal sex, but there are populations that get anal cancer that have never had anal sex. And just to illustrate how common it is to have HPV in the anus, this is a study in women, HIV negative, and women living with HIV, and they looked at the HPV prevalence in the anus and the cervix, and you can see that across all of the groups, there's more HPV in the anus than in the cervix, which surprises a lot of people. You can also see that with increasing immunosuppression, as the CD4 count drops, the rates of HPV go down. So we know that it's harder for the body to clear HPV when you're immunosuppressed, and it's more likely to be prevalent. This is a really important study that was published in 2020. It was a meta-analysis looking at incidence rates of anal cancer in different risk groups. And this is one of the studies that informed the anal cancer screening recommendations that were published in January. They divided the population into men who have sex with men, and males who don't identify as men who have sex with men. And then they looked at females and looked at risk factors like the precancers of the cervix, vagina, and vulva, and then other non-HIV immunosuppressed populations. And just to give you a baseline, the rate of anal cancer in the general population is only about 1 to 2 per 100,000. So it's not a very common cancer in the general population. But when we look at the men who have sex with men living with HIV, their incidence rate of anal cancer was 85 per 100,000. And this is stratified by age, where older ages are another risk factor for anal cancer. So the risk does go up with age. When we looked at men who have sex with men who are HIV negative, there's still an increased risk, but not as high as the people who have HIV. When they looked at people living with HIV males who don't identify as MSM, their risk is quite high as well, as are the females living with HIV. And when they looked at the people who've had precancers related to HPV, vulva really stood out as much higher risk. And we think it's related to everything being very close, and that having vulvar precancer or cancer means that you had a HPV-associated lesion, and in females, everything's very close. The anus is right next to the vulva. They overlap even. And so the risk is a lot higher. And then the other group that really stood out in this meta-analysis was the people who've had solid organ transplant. The females who've had solid organ transplant for at least 10 years had a risk as high as the people who had vulvar cancer. When we're talking about cancer prevention, there's different methods of prevention. Primary prevention is ideal, where we can prevent the infection or acquisition of the cause of the cancer, which in this case is HPV, before even getting it. Secondary prevention is what we're really talking a lot about today, and that's detecting and treating the precursor lesion or anal precancer before it turns into cancer. And then tertiary prevention is treating people who already have cancer to reduce morbidity and increase survival. We know that primary prevention of anal cancer and all the other HPV cancers is possible with the HPV vaccine, which has been out since 2006 and is really very effective in preventing infection with these types of HPV in people who were naive to these types prior to vaccination. And these 9 types that are included are 6 and 11, which are the low-risk types that cause the majority of genital warts. And then there's 7 types that cause the majority of cancers. And the initial iteration of this vaccine had 4 types, with type 16 and 18, which cause 70% of cervical cancers. And then they added the 5 additional high-risk types, which cause the next 20% of cervical cancers. So this vaccine is protective against 90% of cervical cancers. The main message with this vaccine is to give it as early as possible. It can be given as early as age 9 and is recommended between ages 9 to 12. And the idea is to give it to kids before they have any kind of sexual exposures. But we really want to focus on saying it's a cancer prevention vaccine, because unfortunately, we don't have universal uptake of this vaccine. And there's been a lot of misconceptions about, oh, this will make my kids more promiscuous. There's been studies showing that's not true. But giving it as a vaccine for cancer prevention, over 95% effective in preventing infection with these types. We don't have many vaccines that are that effective. And it is approved through age 45, as you can see here. And it's approved for people of any sex assigned at birth. And when it was initially released, it was only for females, but now it's approved for everyone. And we know that giving it to everyone is the strategy we need. to have universal protection. So now moving on to screening guidelines for HPV cancers. We now have anal cancer screening guidelines. We've been waiting for them for years, and they were published in January. The CDC will also be releasing some anal cancer screening guidelines in the very near future, and those will be specific to people living with HIV. We know for cervix, we have American Cancer Society guidelines, the U.S. Preventive Services Task Force guidelines, and the American College of Obstetricians and Gynecologists guidelines. For oropharynx-associated HPV cancers, there's no screening test, but there is an oral cancer screening exam that's actually recommended by the American Dental Association on an annual basis for all adults. So I definitely tell my patients to ask their dentist for this exam. There's no screening for penile, scrotum, vaginal, or vulvar cancer. These are less common cancers that do not justify screening recommendations. However, we know that people who've had cervical cancer or cervical precancer are at higher risk of vaginal lesions, and they're recommended to undergo continued surveillance after being treated for cervical precancer or cancer. Just to mention briefly, these are the cervical cancer screening guidelines. I know this is the Department of Medicine, and you all are doing a lot of cervical cancer screening, and we really appreciate that. And at this time, there's 3 options for cervical cancer screening. And I'm leading a project at Stanford to move us towards doing primary HPV screening. Sorry, that got a little misaligned there. And this is HPV testing alone every 5 years, which is the preferred method recommended by the American Cancer Society and is one of the 3 methods recommended by the U.S. Preventive Services Task Force and ACOG. And this is our team that's working on this project. We're hoping that this transition will help to improve access to screening. The FDA just approved self-sampling for HPV testing a couple of weeks ago, and that's where a patient can take their own test in the office, do not need a speculum exam. And this is something that I think will help to improve screening for people that it's very difficult to undergo a pelvic exam, and hopefully in the future could be used for like home-based screening. So more to come on that, but I just wanted to mention it. This is a study that we published last year on focusing on HPV-associated cancers in sexual and gender minority populations. And we wanted to come out with some organ-based screening recommendations. And at the time, the anal cancer screening guidelines were not out. This is a group that worked on this. And there's many misconceptions in LGBTQ populations about screening for cancers, including that women who have sex with women don't need cervical cancer screening and have even been told that by providers. Transgender males may not get screened even if they have a uterus because of discomfort with the pelvic exam. Transgender non-binary patients may need screening but may not come in for healthcare because of the discrimination and the stigma they've experienced with the medical system. And then we know, we already talked about men who have sex with men and transgender female being at high risk of anal cancer, but at the time there were no screening guidelines. And so we wrote this paper to both talk about this population, sexual and gender minority populations, and some of the unique barriers they face to screening and what would be recommended for screening more in an organ-based fashion rather than focusing on sex and gender. So this is, we focused on which organ do you have? If you have the organ, should it be screened? And these were the recommendations. Now I'm gonna move on to talking about the anal cancer screening guidelines that were just published in January. These were published by the International Anal Neoplasia Society, or EANS. This is a QR code that hopefully you can maybe put it on your phone as a favorite so you can refer to it more easily. Unfortunately, I was on the Stanford network when I created this QR code, so hopefully the Stanford people can access it. And if not, then there is the citation there, and you can look it up. But this shows the populations that should be screened for anal cancer. And we have two groups. We have the higher risk group that I showed you in that incidence diagram. These are risk category A. And then we have people who are at higher risk, but not as high risk as that group above them in risk category B. And we're going to go through these in a little bit more detail. Excuse me. And this shows how to screen and what to do if you have an abnormal result, which is referring for high resolution anoscopy. So going back to this incidence diagram, you remember that men who have sex with men living with HIV are the highest risk group. And so they're in risk group A, and it's recommended that they be screened starting at age 35. The men who have sex with men who do not have HIV are still at higher risk, but not as high risk. And so it's recommended to start screening them 10 years later at age 45. And then I'm going to just go through this, and then we'll go to so when you're talking about people living with HIV, screen the MSM and transgender females starting at age 35, and all other people with HIV start at age 45. And you may know that we start cervical cancer screening at either age 21 or 25. So why are we starting later for anal cancer screening? Anal cancer happens on average about 20 years later than cervical cancer for the median age. And so that's why we're starting screening later to be able to identify true precursors and treat them and interrupt that natural history. When we're looking at HIV negative populations, you should screen men who have sex with men and transgender females that do not have HIV starting at age 45. And the cisgender women who've had vulvar cancer or vulvar HSIL, also known as VIN2-3, should be screened within a year of their diagnosis. And then people who've had solid organ transplant 10 years ago should be screened. They're at higher risk. I'm going to go through briefly what the approaches are to anal cancer screening. This was from a meta-analysis on cytology and HPV-related biomarkers for anal cancer screening. They looked at the data from 36 studies on screening and formulated the overall sensitivity and specificity of these tests. Let's start with anal cytology. This is, we call this anal pap when we're talking to patients. The pap is really a cervical test, but patients understand pap. So we just say it, even though it's really an anal cytology. To say what? Cytology? What's that? So we use a synthetic swab. And so this is not your Q-tip, your cotton Q-tip, because that doesn't pick up as much material. And the wooden stick on the cotton Q-tip can break when you're trying to get a sample. So we use these synthetic swabs. They can be rayon, they can be polyester. And you're inserting the swab about 4 to 5 centimeters into the anus. And then you're putting some pressure to try and open up the folds and get a good sample. There is a learning curve. When you start doing these, you might get some unsatisfactory. You might not have enough cells, but with time, you'll increase how much cellularity you get. The overall sensitivity of the anal cytology is 81%. Specificity is 62%. So not the greatest, but actually better than the sensitivity of cervical cytology. For people in primary care practices, if you don't have these synthetic swabs, you can use a cytobrush to collect an anal cytology sample. And you probably already have these since you're doing cervical cancer screening. And similarly, you would insert it about 4 to 5 centimeters. And this actually, because of all the bristles, gets a better sample usually. And patients tolerate it fairly well. This is the order, the EPIC order that we have for doing the anal cytology. It's called anal pap. It used to be called gyne cytology, and they changed it in 2022, which was nice. has its own order now. And you would put in the clinical history and what testing you would like to get. I am generally ordering a co-test, and I'm going to show you next the HPV testing. I'm ordering a co-test and genotyping if the cytology is negative. I'm getting genotype to help me understand is 16 or 18 there, and that will help me triage whether the patient should have the high-resolution anoscopy. And this is just to show you the anal anatomy. The place we're trying to sample is called the squamo-columnar junction. And many of you may remember that from cervical colposcopy, where we're looking for that SCJ. And we have the same thing in the anus. And the squamous in the squamo-columnar junction is the anus. The columnar is the rectal tissue. And we're looking for that junction. And you're trying to sample the cells from that. That's the area that is most affected by HPV. When we talk about high-risk HPV testing in the anus, this is not FDA approved, but it's very useful in terms of having a high sensitivity. This can be run off of the same swab that you did for the cytology. The sensitivity is 92% and the specificity is 42%. Specificity is lower always with HPV testing because it's so common. And when we look at using the co-testing together, the cytology with the HPV test, the sensitivity is 93%, the specificity is 33%. And in this meta-analysis, they looked at all populations, and here you can see the summary of sensitivity. If anything's abnormal, ASCUS, which is the lowest abnormality you can have on cytology, 81% overall, sensitivity 62%, and then you can see those numbers for HPV testing and for co-testing. And then when we look at the groups that have higher prevalence of disease, you can see how the sensitivity does go up a little bit. So cytology sensitivity is 84% in people living with HIV. The HPV testing sensitivity also went up a little bit, 94%. When we look at MSM living with HIV, it's 85%. HPV testing has a sensitivity of 96%. And when we look at women, where the prevalence of disease in the general population is a little bit lower, the sensitivity is lower, but this is more on par with the sensitivity of cervical cytology. So, and then this is MSM who do not have HIV. You remember they were a little bit lower risk, still higher risk than the general population, but the sensitivity is lower in that group. So all this to say that we do have screening tests. They're not like 100%, they're not the best, but this is what we have right now and what is available to screen your patients. And then I wanted to just mention the digital anal rectal exam, which is another form of screening for anal cancer. When we're talking about the cytology, the HPV test, we're really trying to pick up things at an early stage, at the dysplasia stage or the AIM 1, 2, 3 kind of stage. When you're doing a digital anal rectal exam, you're feeling for a lump or any irregularities. And at that point, it's more of a cancer screening test. So if you feel a large lump, there may be a cancer there. It's really important to do this test along with your anal cytology and HPV tests because they both have value. It's also inexpensive. Obviously, the other thing is that people, I think, have moved away from doing DREs or digital rectal exams for prostate cancer screening. This one is more focused on anal cancer screening. But if it's a male with a prostate, I do feel for the prostate when I do the digital anal rectal exam. I think we moved away from doing them. So this is just one thing that could be reincorporated into clinical practice. And this has the potential to pick up early cancers. And if you can detect cancer earlier, then the better chance at treating it successfully and achieving survival. And we didn't have really good sensitivity specificity estimates, but We just had some presented this year from the Anchor study, which I'll talk about in a little bit, and the sensitivity was 82%, specificity was 87%, which is pretty good numbers when you compare that to the cytology and HPV testing. And what I tell people is to try and go into the second knuckle, and that's about 4 to 5 centimeters. You're obviously going to lubricate your finger, and you're going to sweep 360 degrees. So when you do this, the patient can be in lithotomy, they can be in left lateral, whatever feels more comfortable. I generally like left lateral because the patient's more comfortable and you're able to access the anal canal a little bit better. And when you're doing the sweep, you usually have to turn your body to be able to get all the way around and make sure you're feeling 360 degrees and not missing one spot. So going back to our risk groups, I just want to reiterate who should be screened. And one thing that came out after this study was that this group of MSM who are HIV negative, what is their risk if you break it down by age? And a subsequent study did show that age stratification in this group, where you have much higher risk at age greater than or equal to 60 and 45 to 59. And so this supports that starting screening in this group at age 45, because the people who are 35, HIV negative MSM are lower risk. And then the study also broke down the males with anal cancer by their HIV status and by their age group. And what you can see here is that in the younger ages, most of the people getting anal cancer have HIV. And these are the red color here, MSM with HIV. And then when over time, at the older ages, you can see a much larger proportion of people who do not have HIV that have anal cancer. And so it's somewhat surprising is this men who have sex with women without HIV with larger numbers in the over 60 population, about 67%. But given that MSW is a larger population overall than MSM, then that makes sense. So just to reiterate who you should screen, and when we're talking about screening, we're talking about asymptomatic individuals. And this is MSM and transgender women living with HIV starting at age 35. Other people with HIV start at age 45. MSM transgender women who are HIV negative start at age 45. History of vulvar, precancer or cancer start within a year of diagnosis. And solid organ transplant start 10 years post-transplant. And then that other risk group that in the publication with risk group B are people that are at elevated risk, but not as high as risk group A. And these are people that you should do shared clinical decision-making with about whether or not to do anal cancer screening. And for us in gynecology, this is a lot of our patients that have had cervical precancer, may have had a LEEP or cryotherapy in the past. And so we're gonna offer them anal cancer screening starting at age 45. This is people who've had perianal warts and people who have persistent cervical HPV-16 greater than a year. Most of those patients you will have already referred to gynecology, so we're usually the ones that will be seeing them for colposcopy for the HPV-16, and then we can offer them anal cancer screening. And then other patients that you may see in medicine are other immunosuppressed populations, rheumatoid arthritis, lupus, Crohn's, ulcerative colitis, who are on systemic immunosuppression therapy. And then who should be referred based on the results that you get on these screening tests. So anyone that has ascus cytology or greater, and that's atypical squamous cells of undetermined significance. If you're doing just the cytology. If you're doing a co-test, then you can incorporate that HPV result. If it's ascus and the HPV is positive, we recommend referring them. If it's low grade HPV positive, we recommend referring them. If they have any suggestion of high grade, either HSIL or atypical squamous cells cannot rule out high grade, we recommend referring them. And anyone with HPV 16, regardless of their cytology result, they're at much elevated risk, so they should be referred. These are people that you could repeat screening in. I'm going to go a little bit faster, and these are all. There's a table in this publication that goes over who to send on and who to repeat screening in. So hopefully you can save that as a favorite and refer back to it. And I did want to mention referral to colorectal surgery. When should you refer to peach versus referring to colorectal? We're really focused on dysplasia and trying to prevent cancer. And so if you feel a lump or someone has a lump and they're symptomatic, they're having bleeding, pain, etc., then they should be referred to colorectal because they may already have cancer. And then colorectal here is called GI oncology. So when you're doing the referral, you want to put in GI oncology and then select surgical because there's medical and surgical GI oncology. And they would also be seeing patients that have other anal issues like hemorrhoids, fissures, that have failed conservative management. So that's the distinction between where to refer. And now I just want to show some pictures of the high resolution anoscopy. And these are butt pictures, so I just wanted to give a content warning for people. High resolution anoscopy is examination of the anal canal and perianus using magnification. It's the anal equivalent of colposcopy, which most people learn about in medical school. And we use a dilute solution of acetic acid or vinegar and Lugol's iodine, which it helps to identify lesions. We use them like a stain to identify the lesions. If we see something abnormal, we take biopsies, and they're usually about 2 millimeters, about the size of a sesame seed, very small biopsies. And we perform the majority of these procedures in the office. We use local anesthesia. We use a lidocaine cream and jelly mixture. And then we give an injection after that lidocaine cream and jelly has been sitting there for about 10 to 15 minutes before we do biopsies. We can also offer oral sedation to patients or going to the OR for procedures under anesthesia for people who can't tolerate it in the office. But the majority are performed in the office and patients tolerate it well. Again, we're trying to visualize that squamocolumnar junction, which is about 4 to 5 centimeters in. So we're not going super deep. And here are some examples of lesions on high resolution anoscopy. Here is that squamocolumnar junction that I mentioned. Once you put the vinegar and let it soak for a couple minutes, this becomes apparent. Without using the vinegar, it's a little harder to see. But here you can see how the tissue is a little bit whiter with the vinegar. And this was a low-grade lesion. When we use the iodine solution, it's a very strong iodine. When it's staining like this, it's very dark. That's more normal. And we see that in low-grade lesions. And then the lesions can sometimes be flat like this one, or they can be raised like this one, which is more of like a condyloma. These are all within the realm of low-grade lesions or HPV-associated lesions. They're not precancerous. These are some other pictures of anal condyloma, and they have that characteristic kind of cauliflower-looking appearance. Patients that have these may say that they get bleeding when they have bowel movements because as it pushes past, you can see there's a lot of little vessels along these warts, and those tend to bleed if there's a lot of pressure, especially if they're constipated. And then these are more high-grade lesions, which tend to be more flat usually. And you can see it's whiter, and there's these little red dots, which we call punctation. That's evidence of increased vascularity. Here also you can see a feature called atypical coarse glands, these gland openings. And then over here you can see some of that punctation again. When we put the iodine on the high-grade lesions, they tend to be yellow, so they're more non-staining with the iodine, and that helps us to identify where we should biopsy and treat. And then don't forget the outside, the perianus, because about 25% of anal cancers can be in the perianus. This is an example of a perianal lesion. This is a patient that was seen for multiple like pap smears, ended up getting referred to us because of HPV-16 in the cervix. And we saw this on the exam, which is not normal, and had been complaining of hemorrhoids for several years now. And then on further evaluation and testing, had anal cancer. So if you see something like this, definitely refer. This is not just a hemorrhoid. When it's that red and kind of flat, it's not just a hemorrhoid. And then here you can see hyperpigmented lesions in the perianus, kind of circumferential here, and these were high-grade precancerous lesions as well. This is our setup. We were in Redwood City at 420 Broadway, and so we have the exam table. This is our microscope we use for magnification. The patient's on their left side, and we have a monitor, and most of them want to watch it, and they actually appreciate being able to see. But if they don't want to watch it, we turn it. And then I just wanted to show you what an ablation looks like, so you have an idea of if someone has a lesion, how we go about treating that. So this is one of those flat, high-grade lesions. You can see the gland openings and some punctation there. And we do what's called ablation using electrocautery. And basically, we're trying to destroy that tissue in just the surface epithelium. It's very superficial. Remember, these are called intraepithelial lesions, so we're not going super deep. And here's a condyloma that we're ablating. The condyloma kind of just melts away with the cautery. It's actually very satisfying. And we've used local anesthesia, and the patient has had cream for about 10-15 minutes while we're identifying the spots to treat. And then we've given injections with lidocaine and bupivacaine. And we do this in the office in Redwood City. And the goal is to really just get rid of the lesions, and then we usually have them come back in about 6 to 12 months, depending on what their pathology was. Okay, so let me stop this. And just a few, I'm going to go through the last part pretty quickly. There was a study called Anchor showing that treatment or ablation, like I was just showing you, of precancer lesions does reduce progression to cancer. They looked at people with HIV age 35 and older, and they randomized them to getting treated versus getting monitored every 6 months and followed them for an average of 2 years. The trial was stopped prematurely because they did find lower cancer rates in the group that was treated. And here you can see the Kaplan-Meier curve. These were the people that were treated. They had 57% less progression to cancer than the people who were just being actively monitored. So we know that treatment makes a difference. So we want people to screen and send them on for treatment if they need it. And then there was a study from the Netherlands showing the anal cancer screening, which was incorporated there in 2007 for people living with HIV, does actually decrease mortality from anal cancer. And this is huge, you know, how many cancer screenings decrease mortality, not just incidence. And so this was showing decreased incidence and mortality and lower stage at diagnosis in people who underwent screening compared to people who were not screened. Okay, and finally, I just want to mention my program and how to refer to us. These are the services we offer. We're in Pelvic Health Center in Redwood City. This is my awesome team of MAs, nurses, our clinic coordinator. And this is our website that we're continuing to work on that has some information on anogenital dysplasia. You may see notes from Amy Wong, our nurse practitioner. She's an excellent clinician. Patients really love her. And she's doing the high resolution anoscopy as well as myself. And then we have a new provider that I'm training, Anthony Foe, who you may know from primary care and population health. He's currently a primary care provider in the LGBTQ+ health program, working in Los Altos, and also works in the GRACE program and did a PhD on HPV vaccination in LGBTQ populations. And he started training with me 2 months ago to learn HRA. So once he's trained, we'll have 3 providers doing HRA. There's 2 ways to refer to us, either through the Pelvic Health Center, and you would put my name in for the provider, and it's in Redwood City. And then you would put other and anal dysplasia and put what their results were. The other way is through gynecology. And we try to have different pathways, and we try to make it as like less gendered as possible, but it's possible that your male patients may see gynecology at Pelvic Health Center on their appointment. So just to help, dispel any confusion there. But this is the gynecology referral. There's a section for anogenital dysplasia. You can refer that way as well. So in conclusion, anal cancer rates are rising, and we know that prevention is possible. We would love for you to offer anal cancer screening to your patients in the high-risk groups that we went over. Don't forget about HPV vaccination as another tool in our toolkit. And we know that butts are hard to talk about. People don't bring up their symptoms, so maybe adding a question about anal symptoms in your clinic questionnaire can help prompt them to talk to the provider. And some other take-home points are that most anal cancer is in females, and receptive anal sex is not necessary to get anal cancer. So it's still important to screen if someone has not had receptive anal sex and they're in the risk groups. Primary care does have all the tools right now because they're doing cervical cancer screening, and they have all the supplies for that. If someone has symptoms, please do an exam. Look at the perianus, and one of my colleagues likes to say, dare to dare, do that digital anal rectal exam. And then refer to Peach for any dysplasia-related concerns or abnormal screening tests. Refer to colorectal surgical GI oncology for other anal concerns, or if you feel a mass. So thank you all, and happy Pride. And I will take any questions if there are any.
All right. Wow. Thank you so much for your talk. I know I learned a lot I didn't know about, and I definitely want to get that book that you featured at the beginning. We have a few questions, and I know that we'll take just a few because of time. But one of the questions that came on the chat was: is there an increased risk of anal cancer associated with chronic constipation, hemorrhoids, or functional diseases of the bowel?
That's a great question. We actually did a study on this that I didn't put in this talk, but I presented last month at ASCCP looking at risk factors for anal cancer in women. And we did see that other anal conditions, more benign anal conditions like hemorrhoids, fissures, fistulas were associated with the increased risk of anal cancer. And that was even with a washout period, because sometimes people get misdiagnosed with those conditions before they get diagnosed with anal cancer. So we did a 2-year washout, and even with that, it was a risk factor for anal cancer.
Interesting. Thank you. We have another question.
Quick question, Michelle. Great gram rounds. If someone's a persistent HPV excreter, are there any antivirals that are being developed for that?
Great question. There is a company working on an antiviral. We don't have any that are FDA approved, unfortunately. There are a couple of studies on using cidofovir to treat precancerous lesions, but there's no like standard therapy that's antiviral at this time. Once we get that'll be really like transformational in this field, because that's the whole problem, is the HPV lingering and persisting. But unfortunately, we don't have that at this time.
Amazing. Okay. All right. Another question that we had on the chat was, what is the commercial cytology test used for the anal pap?
You can do the anal cytology from either the ThinPrep or the SurePath. So it just depends on whatever you're using for cervical cytology. You can use the same medium.
Awesome. All right. I know that there are a few more questions, but thank you so much for your time. Really appreciate it. Want to respect everyone's time. And that was a really excellent talk. Thank you so much.
Great. Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.